Fill out your cards and make sure you put them in for the drawing, the bingo cards. Fill out your advocacy cards, and I don't know where Jenny went. Do we have the trial match cards? If we don't, check at the desk. Get the trial match also, as Dr. Kutok said. So I'm going to hand this over to Maria Wellish. I just made you a doctor. She's one of everything else. She wanted to introduce herself, so I'm going to let Maria Wellish. If you haven't heard her, you are in for a treat.
Maybe.
There's a lot of sex talk.
Okay, all right. Thanks a lot. Yeah. My name is Maria Wellish, and I am a registered nurse, a licensed nursing home administrator, also an assisted living manager. But I don't think that's near as important as the fact that I'm just passionate about dementia, teaching dementia, and spending time with you. I want to say something, though, and that is I always get picked for after lunch. Even when nobody knows me, I don't know how, it's like a magnet for after lunch. And usually after lunch, I have nobody who shows up. I mean, it's usually pretty empty. So what I want to say is, you all must want to talk about sex a lot. So I think that's really what brought me back right after. So I want to start, and this is not going to be a real long presentation, but it could be. This could run for 4 days. There is so much about this topic, and it's one that we don't tend to talk about a lot. So, but I want to start out by saying that if you thought you were coming for the book review, The 50 Shades of Grey, you are in the wrong room. You can step outside and maybe they'll exercise with you as I wait. Okay? I think it's always kind of funny to think about, let's see, I'm missing a slide here, but they had me with a slide with Dr. Ruth and myself. I am not Dr. Ruth, okay? We might both be short, but I am not Dr. Ruth. Okay. So I want you all to take a moment and think about that we really would say we don't talk a lot. I mean, sex has become very open on television, but when you look at older people, not so. But how many of you have seen an episode of The Golden Girls? One of my very favorite shows. Did they talk about sex? All the time. All the time. Who talked about it usually the most? Blanche. And then next was Sophia. Sophia was busy, the little older Sophia. Now we have Grace and Frankie, right? So on network. Who knows about Grace and Frankie? Oh, I got somebody over there with their hand up. Okay, Grace and Frankie. What do they do for a living? They make vibrators. Yes, they do. And they sell them online. They try to find a niche. What does this tell you just about our own television network, our programming, our aging, and that these taboo topics are not quite as taboo as they used to be? There we are. Dr. Ruth and Dr. Leah. I think there's kind of a resemblance. What do you think?
Do you want me?
No, I don't really. So I want to talk about the difference, and we'll get into the things involving dementia right there closer to the end, and especially I want to talk about ethics. But I think that we have to make a very distinct distinction between what is sex and sexuality. So one can think of sex, and you can read it with me, as what happens below the waist and in between the legs versus sexuality. Sexuality is the total expression of who we are as human beings. It's our values. It's our attitudes. Our appearance, beliefs, emotions, attractions, likes, spirituality, it's everything. But we don't really think about this, as I say to somebody, penetration. This is just different. The need for intimacy is ageless. And if you think I'm going to hold back here and I'm going to be shy talking about this subject, I'm not. I think it's so important to be open. But the need for intimacy is ageless. We can never outgrow this. It's a need for affection, emotional closeness, companionship, tenderness, concern. I'd like to see one hand go up in here that says that they don't want any one of those things that's ageless. All of us want that in different ways. We all have different likes and dislikes. Culturally, it will be different, but I would say that it is one of the things that we need. So, before we start with dementia, I just want to talk very quickly about what is normal changes in women and men so that we're not associating that strictly with dementia. Women can notice a lot of changes in their vagina. The vagina can shorten and narrow. The vaginal walls become thinner. I want you to know that those women will have less vaginal lubrication, and we need to be careful in learning about lubrication for women as they age, and the use of condoms, and also what type of vaginal lubrication to use, because some of them can penetrate a condom and cause tiny little holes. We can note that vaginal penetration can be painful or less desirable, and hormonal therapy can increase sex drive. And our changes that come with menopause raise and lower. Usually lower during, while we're having hot flashes, and after it's over, people tend to see a greater range in their sex drive. So let's look at men for a minute. Impotence, erectile dysfunction, ED becomes more common as we age up. The average age for the first person to have a problem obtaining an erection is 40. That doesn't mean that that's it for everybody. Sometimes there are so many environmental factors that 40. It can take longer as a man ages to have an erection, and erections may not be as firm or large or as it used to be. Now, I want to come back and talk about this little blue pill again in a little bit, and if I forget, you're responsible for reminding me about it. What causes sexual problems? Well, as we age up, our bodies all of our bodies is changing. Not just what's below the legs, but arthritis, chronic pain can interfere with sexual function. Dementia, indeed, and we'll talk about that. Diabetes, heart disease, incontinence, stroke. Some people will have paralysis from the waist down, but they're still able to experience orgasm and pleasure. And this is why I want to open up the topic. Talk to your doctors, talk to sex therapists, talk to psychiatrists, but don't ignore this topic. It's an actual part of our life. It was God given to us, and we shouldn't just ignore this gift. And depression also has a major effect on this. So what does cause sexual problems? Prostatectomies, medications. You got to know every medicine you're taking, because there can be some medicine that will raise or lower your libido. And when we get to talking about dementia and medications and libido, this can turn into a nightmare for the family or the resident themselves, or the person, as well as the staff. Alcohol, too much alcohol can cause erectile problems in men and delay orgasms in women. So we'll do a raise of the hand. Okay. Sexually transmitted diseases. Who would have thought that I would be standing here talking and aging with a group about dementia and talking about STDs? You are never too old to be at risk, and you have to use protection. Now, it's very interesting because it turns out that young men today, millennials, really know how to use a condom. Put it on, get it off, and do it right. Generations before, the veterans and baby boomers are not as adept, believe it or not, with the use of condoms. So that's a training issue. And so we have correct and incorrect positions of a condom, and if you don't know how to use it. But should we be encouraging them? People said we should be putting these out in communities, independent living communities, rather than mints. I am not voting for that. But I will say that is there anybody that didn't hear the story of Florida down at the villages? That if you have a small community of people or a large community, and they only see each other and they're doing each other, then I want you to know the chances of STDs raises just proportionately. So this isn't something that we're not dealing with. And when you think that it's not that big a problem, I want you to know it is that big a problem. So who do you communicate these questions to? With your spouse, your doctor, your pharmacist, and with your therapist. Okay. Here's Maria's question. You walk in and the doctor will ask you a million questions about your health, right? They maybe even make you take a depression scale. They're going to ask you about your BMs. Do you have trouble with your BMs? Do you have too many BMs? Too little? Are they hard? Are they soft? When was the last time your doctor asked you about your sexual life? Tell me. You can go, and I mean, I haven't been, for a prostate exam, but I can tell you that I have been to many a gynecologist, and not one has ever said to me, "And Maria, are you having any problems with sexuality?" Now, this is a problem. We talked about other issues that the doctors don't talk to us about. This is another big problem because this is lifelong. These are the topics they would like for me to cover in 45 minutes, so let me give you those real quick. Affection and sexuality in the presence of Alzheimer's disease, sexuality and intimacy between individuals with Alzheimer's disease and their partners, staff knowledge and perceptions of sexuality and dementia, reconstructing marital closeness while caring for a spouse, ethics, legality, competency, and we should add LBGT. Okay? 45 minutes. You think I can do it? There is not a chance in hell I can do it. And I know exactly that I am in a holy place, so God forgive me in In addition to the topics to cover, I'm not done, is hypersexual behavior and frontotemporal dementia compared to early onset Alzheimer's disease, intimacy and sexuality and institutional dementia care, those ethical considerations. Sexual functions in normal elders, MCI, and patients with mild dementia and advanced dementia, oh my God, and pharmacotherapy, inappropriate sexual behavior treated with pharmacotherapy. Could I cover all those topics? I want you to know that this has been, I never wanted to be Dr. Ruth. I wanted to teach the 4 differences between the most common types of dementia. That was my big goal to get people. This has absolutely fascinated me. And it has become, the research, and I've even paid people to do research for me for this. So I think it's this important. So there's no way, and you know that I can't cover all that. So I hope I cover what it is that you need to hear today. Here's where I start. I start with staff and family knowledge. There is nothing that makes me more upset than to have young staff members calling an 80-year-old man who touched somebody's breast a dirty old man. He's a dirty old man. He was probably always a dirty old man. And they have all these discussions about the residents, and they giggle about things they're doing. 2 people that find each other in a facility that are holding hands, right? And they'll giggle and they'll talk in the break room, and don't tell the family, and oh, here comes the wife, you better get them apart, right? Anybody seen any of this?
Yep.
I want to hear that louder, yes or no? Yes. This is a major problem for us. And yet, we hire these young people that are embarrassed, they're confused by it, and in this room, I'm going to tell you, you're all confused. You don't know how confused you are. Do you know how many orphans are in this room? All of you. You didn't know it, huh? Because none of you think your parents had sex to Could you possibly think of anything more repulsive than your parents doing that? So you have to be orphans. And yet we bring in a 19, 20-year-old CNA to handle these issues that we can't even handle the thought of our own parents, and we're realistic and know how we had our own children. Now, this comes from, and is Carol Birch in the room? I know she's here, and I know that you can talk with her. Hey, Carol, if you see anything different on this, let me know, okay? Because I know that you've talked about this too. But the presence of dementia diagnosis does not preclude sexual consent capacity. Just the diagnosis does not preclude you from getting capacity to have sex. And so the American Bar Association and the American Psychological Association agreed both together to that definition in 2007. I don't know of any updates since then, do you? Okay. So among couples in which one partner has Alzheimer's disease, 70% reported engaging in physically intimate activities. When I see the statistics of people over 60 and over 80 that are still sexually active, it makes me feel very inadequate. So I have to say that we can talk about that in a few minutes. But age is not a rationale for saying why we don't have sex any longer. 70% reduction. Now this is natural and it is healthy. I love this picture. I have a young man, Michael Olivares, who takes all the pictures for me. I just think this is so beautiful. What we're trying to provide to people, and we talk about this quality of life, right? Is what we all want. Person-centered care. If I hear that one more time, I think I'm going to throw up. PCC, right? Person-centered care means that we recognize that people still need intimacy. And yet we'll sometimes say to staff, don't pat them on the back, don't kiss a resident on the cheek. You know what I mean? That we set these standards of how you do it. Yes, we have to teach people how to interact with people so that we don't elicit those sexual, and everything now, when we're not supposed to use the word behaviors. What are we supposed to use? Oh, come on, I'm sitting in here with the professionals now. We don't have behaviors with people, we have unmet needs. Right? Okay. Well, this gets a little complex because there's a lot of those needs I'm not going to meet. But I will tell you that we can do things, and it isn't all about finding diversion. It is not. It is recognizing it. So staff need and they want more guidance and education. Very simple things that we don't even talk about in orientation. If you have a gentleman or a woman who's masturbating in a public place, can we not just take them off, or do we have to make a big deal about it, tell them to stop that, and we don't do that here, and that's not nice? No. We just can move them. We can have a cover ready just to put over their lap and move them back to their room, you know what I mean, to make them more comfortable. Our job is to teach the staff how to maintain the dignity, person-centered care. Now, if somebody has frontotemporal dementia, this can be like obsessive-compulsive disorder. Bet you can tell me that one's right. It can be obsessive-compulsive for intimacy and sexuality. And so that's not putting a blanket and rolling them out of the room. That's a whole other issue to deal with. But our staff has to know what the diagnosis of the resident is, and what they're doing is that they have no inhibitions. They've lost all of those. So this quality of life, this training of staff stands out for me as the #1 thing that we can do. Okay, the family reactions. We cannot wait for there to be an incident to discuss sexuality, aging, and we shouldn't, if you're not even going to admit your parents had sex, you're not going home to talk with them about their sex life. Am I right? No. But I will say that when you start talking about admission to an assisted living or a skilled nursing facility, and all the things we go through, how many pages do you think are in your packets? A gazillion. There are a gazillion in those packets. Anywhere's in that, do you see anything about sexuality? Not one word. Should it be expected? You bet. And are they going to be shocked when it happens? Beyond, because my mother never had sex. So how could she be having sex with Mr. Jones? Mr. Jones attacked her. Mr. Jones attacked her. In the majority of cases, the family picks the wrong one. It's usually the mother or the father that they think would never do it is the one who is promoting this behavior. When a family comes in and we take advanced directives from them, and I may repeat this in a different slide, so it doesn't matter about the order, I just want the information out. But what I want to say is that when you have a family that comes in, how do they feel if they become attracted? They don't know you anymore. They don't know you as their wife. They don't call you by your name anymore. They kind of like you. They like it when you come and visit. But how are you going to feel if you walk in and see them holding hands with somebody else? It's not a check the box on an application form. This is education. We do not educate families as to what happens in communal living. If you come into my bedroom and you go through my drawers, I want to tell you that I'm angry. I think you have violated me. When this happens in a facility, they are violated. They feel angry for their parent that somebody went through the drawers, right? Is it a normal part of some people's dementia?
Yes.
Scavenging, hunting? Absolutely. Did we tell anybody to expect this? It is such a shock to walk in and find somebody going through your drawers. And in these cases, both sets of drawers, okay? The family reactions are our responsibility because we're not training. We're not teaching. We're not getting them to expect what's going to happen in communal living. And that everybody doesn't have the same kind of dementia as the family member that you're admitted to this place. And it's no different than when you go to college and somebody borrows your clothes. It's no different in any type of a communal living, but we don't teach it. So here's what happens. It's the last taboo, so we're going to make a policy and a procedure. I don't think so. I don't want a policy, because when CMS comes in, or the state comes in, and they're going to take the policy over anything else, right? Your policy, the strongest, is what they're going to follow.
Right.
What are you going to write in the policy? So when somebody said to me, what are your procedures and policies? I couldn't possibly, with person-centered care, come up with a policy that would meet the needs of all the people that we have. Protecting our residents and safety? Absolutely. Absolutely. So let's just really get over what is hypersexuality first. And one of the dementias, the behavioral variant of frontotemporal dementia, appears to be really likely to have increased sexuality. And when I say this, I don't mean a little bit. I mean a whole lot usually. A whole lot. A doctor must be brought in on this. They can hurt themselves and they can hurt others. And that is something we're held to as responsible in our facilities. So, what is it? Well, it's excessive time consumed by sexual symptoms, hypersexuality in response to dysphoric mood status, in response to a stressful life event. That happens to them. They're stressed all day long in our facilities. Is that not true? Noises, buzzers, bells. Repetitive but unsuccessful efforts to reduce or control the sexual symptoms on our part as a staff or a family member. If you're a family member, this can happen in your home. Repetitive engagement in sexual behavior at the risk of harming themselves or others. People don't realize that if somebody masturbates all day, it can really cause damage to their body. We need to get a doctor in on this, and we need to teach our staff about that. So, pharmacotherapy. This is a long topic all in of itself. Is do we treat with medications? We have gotten so far away from using psychotropic drugs that trying to put these in. And I have a whole study, and anybody who would like to meet with me afterwards for a few minutes, I'd be glad to go over these studies, or you can call me or get hold of the Alzheimer's Association and reach me. But I would say to you, this is one you really want to talk about with your pharmacist, a geriatrician, somebody who understands meds, because the side effects sometimes are much worse than what the hypersexuality or sexual behaviors are. Caring for the caregiver, I can't say this enough. So let me start with a story that I love this story. That I met a family at a conference up in Washington, D.C. And he had just been diagnosed. He was an executive with AT&T at the time. And he had just been diagnosed with Alzheimer's. It was a shock to them. And this man, first diagnosis, you would have absolutely no indices at all that he had dementia. And his wife, just a handsome couple, beautifully dressed, lovely. I don't know what gave me the idea, but we had a filming company that worked with the organization I was with. And I said, could we follow you through the disease process? And they thought about it, and they said, that would be wonderful. We could really give back. So we did. They lived in Houston. And I was able to travel with my team on many occasions to film and watch them as they went through the process, and we asked questions. And I said to them when I met them, and this was my very first thing, anything I ask you that you don't want to answer, all you have to say is pass. And we'll go on to the next question. I understand that. This woman said to me, oh no, we won't pass on anything. She said, we'll talk about anything because I know you're talking about sex. And she said, and the only reason we got married was to have sex because we were in college and you couldn't have sex until you got married, so we got married right away. So here was a family who was going to talk to me about anything, and they did. And they talked about, with their family, they talked about all the things that they had covered for advanced directives, and they were talking about their sex life. And I thought it was pretty open of them to do that. And we were not publishing this. Everything usually went out live. We were holding off on this. So on the third trip to visit them, I get out of the car, and the team is unloading the equipment, and she takes me aside, and she said, Maria, don't ask me any questions about sex. I'll tell you later. I said, okay, that's fine. Pass. So I met with her as I was leaving, and she said, I do want to tell you. She said, my husband still very much wants an intimate relationship. We had a very active sex life. She said, but I now feel like a pedophile. I am taking care of this person just like a child. And when he wants to have sex, I feel like I am violating him. I feel like a pedophile. And I don't know how to handle these feelings. Can you imagine all the emotions that we don't know that people are going through? What a wonderful couple to share that information with me, to be honest, to know that he still wanted it, how hard for her. I love all the people who are open to share with honesty, but I know this is a particularly hard topic. So what we want to make sure is that we are providing quality of care. So I want to give you a case study. And if I mess up the case, Carol, let me know. But I don't remember all the names and everything else. But anyway, here's the gist of it. And you can hear it on YouTube. You can go on and listen to the case. But it was a case where a gentleman, it was his second marriage. He had been he and the new wife had previously been married, widowed, and had been married for more than 10 years in this second marriage. Children totally in favor of it. No problems there. Happy family, got together for activities, and the wife develops dementia. Eventually, he can't handle her at home, so he takes her to an assisted living or a skilled nursing. It was a skilled nursing facility. He visited her every single day. That was the one thing the staff testified to. He came every single day. They held hands, they kissed. He kissed her before he left at night. And a staff member or a visitor recognized they were having sex and reported it, and it was called into the police because it was rape. Because she was not cognitively intact to make the decision to have sex. So at that point, then if you don't know what you're doing, we talk about young girls in college, if you're drunk, You know, you can be raped. So what's the difference with this? This man was a state legislator, so you can imagine the impact of this on the front page of the newspaper, what his life became. And do you know that this actually went to trial? And he was exonerated from this. It was not considered this. One of the things is that I say we have to use good common sense. And you'll see this on one of my final slides. How do we know if somebody is consenting or they're not? I want to know how we know that they're consenting to go to activities when we take them, unless they're pulling away not to go. They're not really consenting. We're just saying, you're going and you're going. We're going to dinner and you're going. We're going to the bathroom now and you're going. We teach staff that if the husband or a visitor comes and the person becomes scared of them, they cry out, they don't want to come out of their room, they start to socially isolate. These are signs that they're probably being abused, that there is some sexual abuse or other type of abuse going on. We have lots of things to teach people, and we do, about abuse. Why would that be different than this woman who is so happy to see her husband come in the morning, kissing him goodnight, and yet when he snuggled up in bed, and we don't know whether there was penetration or not, do you know what I mean? But they did say that she was taken to the hospital and had to go through a rape kit. I want you to think about this, something that we don't talk about, do we? In your buildings, when was the last time, or as a family, have you talked about sexuality and been open and honest? I want to see the hands. Mark, are you raising your hand or just raising your hand? So, we can't get away with this without talking about ethics. We can't. Are we supposed to have an ethics committee if we are an organization? Yes. Do we? They're useless if we have it, usually, is what I've seen as I consult. We can do case studies with our staff, and we should. I think I brought 100. I'll leave them on a back table if you just can't make one up. State regulations tell us what we have to report and what we don't. And I don't get into this because I've learned something about regulations. No matter how I interpret them, the regulators interpret them differently. So I don't get into them. But you can go under for assisted living, skilled nursing, because the laws have changed on resident to resident and whether somebody is cognitive or not. So I want you to read it yourself. Legal authority, to call the police and say that somebody's been raped. What do you think they're teaching young policemen today about rape in an assisted living with a husband and a cognitively impaired wife? Pardon me? Nothing. Nothing. We're lucky that they know somebody has dementia, right? Or diabetes. I'm going to come back through everything in my career, everything for all the years that I have spent, and now, I mean, I've been a nurse over 40 years, but I have been in long-term care and assisted living for over 25 years. And I will tell you that the majority of times the decisions would be well made if we would just use some good common sense, discussion, and education. We go through so many programs and so many certifications that really it's common sense. So I want to thank you because you've sat here, and I mean, I haven't even used my time yet. Oh, I have almost, haven't I? Where are we, Byron? Where are we, anybody with this? How many? 20. Oh, I have 20 minutes still left? Woo! All right. So, let me ask you this. I want people to age successfully. I want them to sexually age successfully. And I want us to be open for a few minutes, and I know you have stories from where you've been, where something has happened. I know you have. If you've worked in long-term care, you got a story, right? Somebody's fallen out of bed and broken their hip, and you've been sued, right? And if we run out of stories, I'll give you mine, because I've been through all of them. I've even been deposed over this. So very comfortable. But what questions do you have? Oh, this taboo subject that we can't talk about. Yes, ma'am.
So what are some of the, you mentioned that there have been some changes in regulation when it comes to resident.
Yes. And the cognitive to non-cognitive, and it's changed by state. And since I teach in all 50 states, I would say to you that I have not learned every single one of them. But I will say that it has become that they want us to report more, not less. And it's better to err on the side of reporting, and I'm going to go back to Carol. Better to err on the side of reporting than not reporting?
I would say that for the safety of the facility, that's probably the case.
Absolutely. Now, give her back the microphone, please, Byron. Absolutely, for the safety of the facility, so we don't get sued, and we have to follow regulations. That's not an option for us. For the effect on the family, what does this have?
Well, I would say the effect on the family is, I would say the effect on the resident is detrimental, and the effect on the family is questionable.
Some families, thank you, are very open to having the discussion and how we broach it. And do we know how to broach it? Can we comfortably broach the subject and bring in the daughter and bring in the son? And who do you think is, out of the family, the son or the daughter, is going to be most upset about this?
The son.
Always. It's always the son. Hardly ever do I have it be more the daughter. It's usually the son that gets most upset about this. Yes.
I'm over here. I asked the question just a second ago.
I'm lost.
Over here.
Okay, sorry.
So with regards to reporting and just your opinion,
Yes.
if you've had the conversation with each family member and you've documented in a service plan, would that require reporting it to the state?
Yes. And the reason is, even though that you have done that, you are going to have staff members who have different moral values than you do. They have different cultural values. And they're going to call it in to the state as abuse that you didn't report. Had you and the best thing is get it all documented, but we should not be afraid to call in anything. If we have covered ourselves, and I know that there's always something, that we talk about our ratings and our everything else, I say common sense tells you somebody's calling that in. And you better be prepared, because you're in more trouble if you don't call it in than if you didn't.
Maria, here in the center.
Thank you. Let's start one more time. I'm sorry. Go ahead.
For the reporting purposes, is this spouse to spouse or resident to resident?
Either way. Either way. If there is any, now, if you walked in and everybody was happy and nobody was upset and all the staff was well trained and you went through this in the report, nobody, voiced anything of concern. The husband was okay, the wife was okay, we're good. Now, let me give you something else. What about the case of Sandra Day O'Connor, whose husband was demented, who fell in love with a woman at the assisted living facility or skilled nursing, and they had sex? What do you think? The Supreme Court judge. What would you do then?
Report.
Do you want me to tell you what was interesting? She did a film on giving permission for it and did a case care plan for it and allowed for it and wrote that she wanted her husband to have that intimacy and that she gave permission for it. I wouldn't call that one in. This was where there was real dialogue, and this was somebody who really understood. And you know how she took it? If he found intimacy that wonderful with me, he would want it again with someone else. And that to her was a statement of, and there's a whole film on that to show to the staff, because she talks about it and how she came to that decision. In that case, it was care planning. In the care plan, signed by the family member that was in charge. What happens is that we confuse who has the medical power of attorney. And we need to remember, is this a medical issue? That's where I get confused. That's why I'm doing more study on this. Is sexuality really a medical issue, or is it a social? What kind of issue is it? Because there are lots and lots and lots of married people who have no problem having affairs. And they don't think anything's wrong with it. There's wife swapping. There's all sorts of, there's more than I wanted to know that there is going on in this world. I'm sorry, please let me take your question.
I wanted to bring up the case that happened not too long ago where the young woman was in a coma and she gave birth.
Yes.
No one called that in.
Would I call that in?
No, somebody should have been calling somebody.
Let me tell you,
how did that
not only yes, hell yes, and I would have called it twice. There's no question about that. There is no way she could possibly give consent for that. There is no way that should, I mean, that to me is just,
It's right.
there's no question. There is no question. That is indeed rape. That is indeed rape. And it is our job to protect people from this. And we should know what's going on in rooms. But what about privacy? Quality of care. How do we provide privacy? You know, we could have conjugal rooms, but I think that could be strange. I don't know. Somehow putting me in a chair and wheeling me down with my husband to the conjugal room and coming out during dinner might be kind of embarrassing. But the other thing is that families come to us and say, we want privacy. We should be able to put a sign on the door and have the roommate leave for, if we have to have roommates, be able to leave and do something wonderful with the roommate for half an hour. Do you know what I mean? But to allow people
I thought it
privacy.
was a sock.
Pardon me?
Isn't it a sock on the door?
Listen, you were too busy. Oh my God. Now they don't care, they just walk in on each other. It doesn't matter, they'll watch. Go ahead.
You said you were not going to leave out the LGBTQ dementia, seniors with dementia.
Absolutely, absolutely. This is a topic that really has not, I mean, when I went into nursing school, we never discussed it. Just like they were asking, did we talk about geriatrics? I mean, these were things that we never even, we're not talking about sex in this room very well. So let's now get into LBG, you know, let's get into all of this and understanding it. They have exactly the same rights as we do. It has no difference whether you have a black wife and a white husband. To have your sexual preferences recognized. This is person-centered care. You made the choice in your life, and we have a responsibility to respect it. Absolutely. I will say that in the studies that I have read, all of them say not enough research has been done on this. That it is really lacking in this field. And also, when it's a very interesting thing to talk about transgender, about room assignments and things like that. So I mean, this could become a full day topic. You can understand how really, but we can't ignore that. You forgot to remind me about the blue pill.
I tried to raise my hand a minute ago.
Okay. She forgot. No.
No, I'm very interested.
Okay.
If you're looking for more information about elders who identify as LGBT or who don't identify as LGBT but are, Sage Care
Yes.
is a wonderful resource for LGBT older adults. And they are really on the vanguard of doing that kind of research, of capturing those stories, and of working to balance privacy issues with safety issues and exploring and affirming the sexuality of all humans.
And they do train them.
They do training.
And by the way, we're Sage Care Management out there, so that's not us. I mean, not but it is out of, no, but out of DC.
Yeah.
And they'll train your staff. It's fantastic.
It's incredible what is available, but we have not gotten it out. It's not there. Listen, we haven't even gotten down to the CNA, what to do if you walk in the room, do you know what I mean? And somebody's masturbating. I mean, so we've got a long way to go with this.
One of the things that I think when you're working with CNAs is to talk to them about thinking about whether residents live in our work space or whether we work in their living space. And that's a change. It's just a little change in perspective, but when, it's a matter of empathy. When they start empathically thinking that we're in their home.
And it's no different with dementia. I live in their world, they don't live in mine, right? Okay, the little blue pill.
Yeah, get it.
The little blue pill wasn't there when I started out in nursing school. And I can tell you that I worked, I guess I didn't say this, I worked at Air Force Village for many years. And at Wilford Hall, I saw a sudden increase in sexuality and found out about the amount of doctors that were prescribing Viagra being asked for by people that were in independent living. But then it turned out as they were moving over to assisted living and memory care, the doctor didn't know they had moved. And so they're still prescribing this, and maybe not appropriately any longer. Maybe not appropriately in that environment. Any other questions? Yes, ma'am.
I have a huge question. Okay, so, with the HIPAA thing, and when you have two patients and you have like sexually transmitted diseases and you're aware of them, but you have your HIPAA things, and you have two patients that are like, you know what they have, but you're not allowed to say anything, how do you intervene with that?
How do we deal with that?
Yeah, how do you intervene with that?
Okay, the same way that we do with anybody in the general public. That is a CDC issue, communicable disease, and a public health issue. And they have people who are trained that do the background checking on that. And we still mark it down, we still notify the doctor, do you know what I mean? But we really have to never leave out the organizations that track this, that know what's going on and know how to contact, because I guarantee you, it probably won't be just those two people. So it needs to be handled in a very effective legal manner. That's a great question.
You see that in the nursing home. That's why I'm just like, but you can't go to that patient and say, hey, this person has this, don't be, trying anything with them. You can't do that because of the HIPAA rights. So that's why I'm like, how do you handle that?
Well, I would say that first of all, you have to think about your own infection control. And so you need to know that if they're roommates or whatever, in this kind of a situation, you're going to be moving to private rooms, you've got to use common sense. Do you know what I mean? Before we even bring in outside agency. But at that point, we do need to bring in, and we don't know that that isn't rape. We don't know that there isn't somebody working on our staff. So that's why we are, you know what? For some reason, we take on the ideal when we work in long-term care, assisted living, that we are like the crime scene investigator, CSI. We are not. We report and somebody else investigates, to be honest with you. Yes, we do our small one, but we're not the final end-all. And we really need to bring in the professionals. And I would say the professionals are CDC and public health in those issues. I keep thinking, Mark, you want to ask a question. I know you're dying to ask a question. Go ahead. He keeps putting his hand up. Do you want me to know that I have 10 minutes left? Don't you? I think that's just plain rude.
What's that?
So, I will tell you that I had a family in one of my facilities, assisted living, and this woman was very aggressive. She was beautiful, and she was very aggressive, and the gentleman that she selected was just a handsome, handsome man. She had great taste, and she was beautiful. And I'm telling you, she went after him, and better be nobody else giving him any attention. She would change seats in the dining room. She would push people off the couch to sit next to her. She would hold his hand, she would follow him to bed, and when we brought it up to the husband, because it is our rule when we begin to see, even though there's confidentiality, that we've noticed a special relationship building. There's nothing wrong with bringing that up. You would be the same as if it was two women that were knitting together that have become good friends. So just bringing this up. This gentleman walked in, and the gentleman was in her bed. She had actually, I think, lured him in. I mean, we had watched enough of this. I learned a lot of lessons because it was one of my earlier cases. I have never, ever felt as attacked in my life. I was a promiscuous bitch, by the way, when I presented the case to him. And he almost came across the table to strangle me. He was so angry. This was such and I look back and say, our mistake was that we did not advise him how intense this relationship was building. We did not, because he blamed the man, not his wife. There was no question but the wife was instigating this relationship. There wasn't anybody on staff that wouldn't say not. But our fault was we did not communicate with the family the changes in personality, behavior. I own that one 100%. 100%. And we're going to make mistakes. In this job, we're going to make mistakes, but these are serious ones. And they matter a lot to families that have had intimacy for years and years and years. I mean, some people married 40 years, and now they're having sex with somebody else or holding hands when they walk in with another woman, and they don't know them, and the emotions that are involved here. This is huge. This is way bigger than a 45-minute to an hour presentation, for sure. Yeah. Yeah. And great experts on this too. So, any final questions or comments? What would you think I should add or delete from the next session?
More time. Add more time.
More time. Pardon me? Slow down? Come on, I'm taking you back to those slides for 45 minutes. You're right. Slow down. Thank you. I appreciate that. It means there needs to be more time. Thank you very much.
And on the mountainside, the summer's gone, and all the roses falling. 'Tis you, must go, and I must